name is Shyam Patel, and my presentation is on optimizing pediatric cancer survivorship. I wanted to thank my mentors, Dr. Linda Dahlquist and Dr. David Eisenman, for guiding me throughout this process and lending me their expertise. I also wanted to thank my advisor, Carrie. Like Liz, like Liz said, she's been my rock for the last 4 years, and she's really been there when times have been difficult for me. I also wanted to thank my mother. Her battle with cancer really showed me that remission isn't recovery. Like, the journey goes well beyond remission into survivorship. It's a difficult battle, even when you aren't going to chemotherapy or radiation. And I wanted to see what I could do to prevent these adverse outcomes occurring in children. Okay, so currently in the United States alone, 80% of survivors are expected to live 5 or more years beyond remission due to medical advances in technology. And there are 330 survivors approximately currently, and the number is going to grow over the next couple decades with even greater medical advances. However, the bad thing is about a significant portion of these survivors experience one late effect, and 25% of these late effects are life-threatening. So my research focus was regarding looking at common late effects that were seen in the literature across multiple disciplines, and I wanted to see what issues there were in healthcare delivery and organization. I wanted to see what I could do to resolve these late effects and come up with a recommendation for an interdisciplinary treatment model. My methodology was a widespread literature review. I only used peer-reviewed academic journals that were published after 2000. Anything before would be irrelevant due to changes in medicine. Every decade there's new advances, so you can't really use anything in the last couple of decades. One of the perspectives I looked at were biological and medical late effects. One of the most common late effects is secondary malignant neoplasm, or secondary cancers. This accounts for 16% of all pediatric cancer, or all cancer incidents in adult and pediatric populations, and it's also the leading cause of survivor death in some cases. The other bad thing is one subsequent malignant neoplasm predisposes for other cancers, so you can have third and fourth cancers just from getting a secondary cancer. There were certain risk factors. The age and initial diagnosis for your primary cancer. If you were older or an adolescent, you were more likely to get a secondary cancer as opposed to a younger child. If you receive radiation, especially in the cranial and the chest area, that increased your risk. And your primary cancer diagnoses also affected your chance of getting secondary cancer. For example, Hodgkin's lymphoma and brain tumor patients were at the highest risk. One thing that was disturbing was cumulative incidence at 30 years of survivorship. So after 30 years of surviving, 1/5 of all survivors will get a secondary cancer. So it's really high risk of getting secondary cancer. The other thing I noticed was genetic susceptibility. So when you have primary cancer, you're already at a weakened state. Your DNA can't be repaired easily, so mutations are more prominent and it causes cancer. But when you get secondary cancers, your body's already gone to radiation treatment that further damages your DNA. Because you have compromised DNA repair system, it predisposes you to get even secondary or tertiary cancers. Hereditary mutations also come into play. So families with Lee-Fraumeni syndrome, they have mutations at the p53 gene, which is a tumor suppressor. So some individuals are predisposed to, their tumor suppressors aren't working, they're more likely to get tumors and cancers. There's also genetic variability in pharmaceutical drug disposition, so how well your body metabolizes certain drugs. So this comes into play with chemotherapy. So certain drugs have more negative effects on survivors than others. There's also non-malignant sequelae. This is not life-threatening, but it still lowers the quality of life. Number one thing I noticed was cardiac damage due to certain chemotherapeutic drugs called anthracycline. 60% of all pediatric cancer patients receive anthracycline, and it causes valvular disease, myocardial infarction, myocarditis. Another common drug that's used in cancer populations is bleomycin, and that causes pulmonary toxicity. So these individuals can't breathe, they have fibrosis in their lungs. Another thing that I noticed was endocrinal deficiencies. So if you got cranial radiation, that affected your growth hormones, and you would have GHD, which is growth hormone deficiency. It resulted in stunted growth and developmental issues. Finally, musculoskeletal strength deficits were noticed. So most cancer patients, after they survive, they can only do half the physical work that a normal, healthy person can. Looking at the psychosocial perspective, I saw other issues But overall, and surprisingly, there's a positive emotional health seen across all pediatric survivors, but differences only existed when we did within group comparisons at the subtype level. So certain cancers, you are more likely to gain adverse psychological outcomes. So if you have leukemia, brain tumors, or lymphoma, you're at higher risk for getting depression, anxiety, or other adverse psychopathology. CNS treatment involving cranial radiation resulted in brain damage, and 40% of survivors had neurocognitive deficits. So that means you have problems with your memory, processing, speed, and that led to adverse outcomes later on with school and education and getting employment. Another common thing that I saw with PTSD, 20% of survivors had post-traumatic stress symptoms. This was correlated with higher psychological distress and lower quality of life. Things that affected PTSD development were treatment intensity. So if you had more rigorous radiation or chemotherapy, you're more likely to develop PTSD or late effects. So let's say you had a very, you can't walk as a result of radiation or like muscular atrophy. That's going to be more traumatizing for a patient than someone who just, got a needle or like a shot. Another thing I saw, surprisingly, was resilience seen in cancer patients. A lot of kids actually see this, they grow from their experiences, they become stronger individuals as a whole, and that may explain why the overall trend is the positive outcomes seen in cancer survivors. Finally, in the healthcare perspective, there were also other issues. So when you're in a pediatric cancer environment, you're kind of sheltered. You have, your pediatric oncologists, you've seen them for 10 plus years, but then when you turn 18 or 21, you need to shift toward adult-based primary medicine. And that leads to anxiety issues and trust issues. You've seen one person for, most of your pediatric healthcare life, and you trust them, and now you're moving on to someone who doesn't know your case as well as your oncologist did. There's also issues in gaps in knowledge. So a lot of pediatric cancer survivors, when they were 7 or 8, they didn't realize what they were getting, what kind of treatment they had. So they aren't able to recall these treatments later on their adult, when they see their adult primary care physician, and that limits the care that they receive in adulthood. Another issue with long-term follow-up care, only 31.5% of patients receive risk-based care. Risk-based care is when your doctor assesses what your previous therapies were and what are the risks of developing adverse outcomes as a result of those therapies. So let's say you had anthracycline drugs when you were younger. If your doctor doesn't know if you got those or not, they don't know if you're at higher risk for cardiotoxicity later on in life. Other issues are institutional processing and follow-up. They noticed that pediatric cancer centers weren't doing a good job of following up with survivors and tracking their care after they left the system. And you also see patients with PTSD were also avoiding long-term follow-up care. So they didn't want to be in that situation. They didn't want to re-experience the traumatic event that they went through before. And finally, health insurance is a big issue. A lot of insurance companies don't want to cover patients who have cancer because they're at higher risk of developing cancers later on. So I took all this information and I started to integrate it to develop my recommendation for a comprehensive treatment model. The first thing I did was redefining recovery. At a biological medical level, a lot of doctors think recovery is based on remission. The cancer's gone, yay, it's done. But we need to extend that definition of recovery from remission to long-term outcomes, make sure they have healthy adult lives as well. So I built my complex and multi-causal explanations to describe the phenomenon of pediatric cancer survivorship, and I bridged the explanation action gap by using dramatic changes in healthcare policy to kind of bring about the resolution of these late effects. For biological and medical recommendations, I am emphasizing long-term surveillance and patient education. These patients need to see their doctors routinely after remission. They need to get their physicals, their screening, and they need to be educated on what kind of therapies they receive and what risks are associated with those therapies. There needs to be further gene sequencing to see what genetic alterations are caused by treatment, and do individualized targeted gene therapies. So, map out a person's genetics and then see what we can do to actually fix those, correct those DNA damage. And then we also need to reduce therapy-related toxicity. So right now there's a new phenomenon of radiobiology, so it's looking at how radiation affects genetic changes and reducing those changes. And then we can look at alternative drugs. Like I said, 60% of patients receive anthracyclines, but new studies have demonstrated there's a drug called doxorubicin, and that actually reduces the cardiotoxic effects of anthracyclines. So we need to use those kind of drugs. On the psychosocial level, we need individualized treatment plans. So, addressing depression, anxiety, other psychopathology as they arise. Some studies have demonstrated that initial clinical-based intervention at the time of diagnosis and treatment, like preliminary treatment, is most efficacious in reducing long-term adverse psychological outcomes. We also need to target cancer therapies as primary prevention. So if we're able to fix the adverse outcomes associated with anthracyclines or radiation, we reduce the number of medical late effects, and that increases the overall quality of life later on in life and reduces psychological outcomes. We also need to do neurocognitive interventions for cognitive remediation, and behavioral therapy is effective in reducing neurocognitive deficits, and we need to do educational and vocational programs to help these individuals adjust later on. And we also need to work on minimizing the effects of PTSD, and we need to do early risk screening at the treatment level. And for healthcare, at the institutional level, we need formal protocols in place for follow-up and tracking. We need interdisciplinary transition and care teams, which are comprised of doctors, both pediatric oncologists, primary care physicians, psychologists, and social workers. And we need to stress that long-term follow-up needs to occur at the original cancer center, so it's less of a transition, less of a burden on the survivors. We also need to prepare and educate doctors in training. So at the medical schools, clinical survivorship, cancer survivorship needs to be emphasized. And for insurance coverage, the Affordable Care Act actually resolves a lot of the issues that cancer patients were facing before. So in conclusion, I want to stress again that remission is not recovery. Patients do face a long battle after they beat their cancer. We need to implement standard protocols across multiple cancer institutions. It's good to hear that certain hospitals like CHOP, Boston Children, MD Anderson, and St. Jude's have implemented interdisciplinary survivorship clinics. We also need to adjust current cancer therapies and develop new ones that reduce toxicity. And we need to do future research to see how efficacious interdisciplinary clinics really are. So thank you. That's my presentation. Question? Can you guys speak up when you ask questions? Because I can't hear.
Sure.
Yeah.
A question for you. So for the issue of transition to adult care, which, as you identified, is a huge problem for going from pediatrics to adult care, what suggestions do you have for people who can't go back to their original facility?
I would suggest sharing, like I said, some hospitals need to do processing guidelines to develop them to kind of bundle and prepare patients as well. So, give them documentation of what therapies they received and make them understand that there's certain risks associated with these therapies, and emphasize screening and physical examinations every year, and kind of give them that information so they're able to use that when they meet up with their primary care physician later on. So I understand that some people can't go back to their cancer centers, but it helps to actually prepare them beforehand as well. They can't go there.
Along the same lines, you said one of your recommendations was the follow-up care should occur at the original institution. Were any of the places you mentioned at the end doing that? It seems like you might get resistance from the hospital to doing that sort of program.
So this summer I worked at Children's Hospital of Philadelphia. They have a survivorship clinic. So as soon as they begin to transition from remission to adult-based care, they actually set up the transition process for these patients. And I saw patients coming in to the original cancer centers and receiving care. So I saw 30-year-olds and 40-year-olds still coming back to his institution. So it's working in some areas.
I would think that parents would play a very important role in kind of bridging the child's the processing of their experience into adulthood. Do you see anything in the literature? Do you have any ideas about parent education and facilitating, quality parenting through this as a way to support?
So a lot of the anxiety I was talking about is actually related to family dependency. So children dependent on their families, and now they're being forced to be more independent as adults. But some studies have shown when we do pre-treatment counseling with the families, educating the families is also efficacious in reducing adverse psychosocial outcomes, because the families are then able to educate their child later about their therapies and what risks are associated with those therapies.
I guess this is a really nebulous question, but is there, do you sense a hierarchy in the way that medical professions treat the various disciplines that you've addressed here? Is there a tendency to think genetic factors are more real, more pressing than?
So the reason, like, to CHOP has that interdisciplinary team is some doctors do focus on, beating the cancer,
Right.
stop it there, but then they don't really realize that their actions also have long-term, like, psychological damage. That's like, so like, trying to reduce their trauma in the initial treatment phase isn't as much of a priority for doctors as, it is for psychologists. So yeah, there's differences, which is why we need to stress interdisciplinary care as a whole. Does that answer your question?
Yes.
Okay.
Thank you.
We've seen in recent years a lot of medical technology development which has allowed more options for cancer treatment. Would you include that in the array of possibilities for the future for increasing pediatric?
Can you repeat the last part of your
If you
question?
had more advancement in treatment technology so that we have a larger array of options for pediatric cancer patients, is that?
I can't hear you, I'm sorry. Can someone?
I apologize. So if you are looking for survivorship for pediatric patients, what about technology? What about the way that you actually physically treat the cancer? We've seen advances. Is that
Like how-
another option of increasing survivorship, advancing technology?
Well, advancing technology kind of helped survivorship outcomes because before in the past we were seeing more mortality associated with pediatric cancer. Like advances have helped reduce that, but we also see that these advances aren't exactly great. Like some of the technology that we're using, like radiation, horrible side effects for cancer survivors, and that's why new fields of we're observing radiobiology and radiogenomics. Like they're using new technologies to reduce the effect of radiation. So we do need to work on developing technologies that work. But this research I'm doing now, in 10 years, it's going to be completely different with new medical advances because, last 10 years ago when I was looking at data, some of those things don't even exist anymore. They've changed the therapies that they use, and now, in 10 years from now, there'll be new therapies, and they're going to have to redo all this research. But they have cohort studies, so right now, the CCSS, the Childhood Cancer Survivors Study, they do 30-year cohort, and right now that cohort is where most of this research is coming from. They're going to have to redo that next couple of decades.
But let me, if I could follow up on that, but what about the psychosocial impacts that you were talking about? If you looked at those, if you look at a different cohort, are those psychosocial variables, are they that different? Is there less PTSD? Are there fewer of those kinds of issues that really don't have as much to do specifically with the treatments?
Yes and no. When I was looking at older data, you still see higher rates of traumatization and adverse psychosocial outcomes, but the rates change every now and then. They're still pretty high, they're still significant, but they'll change with new research. So I think most of this data is the current cohort, but after we look at other cohorts, we also need to examine how that differs.
Right, because I was just wondering, you were saying, well, all of this will have to go out the window, but I was wondering if some of those sort of issues that deal with the patients and how they relate with their families and to their treatment.
Well, some of that is constant because doing pre-treatment counseling, that's really important. Acknowledging what risks are associated and teaching these kids later on before they reach their adult primary care physician. This is what you had. This is what you need to be aware of. This is what your risk of developing. That still needs to stay the same, but otherwise, I think it does change from cohort to cohort.
Well, thank you. You're finishing right on time and finishing the session. Thank you very much for